Hello and welcome to India Top Doctor. Today we will talk about perioperative management of diabetes. And for that, we would like to invite Dr. Devyani Sankpal. So let's invite her. So welcome to India Top Doctor. As you know, today we will be talking about perioperative management. So before we move ahead, can you tell us what is that?
See, perioperative management is management of hyperglycemia before, during, and after surgery. See, what happens in most surgeries, whether it's a general surgery or cardiac surgery, there is kind of stress hyperglycemia, whether a patient is diabetic or non-diabetic. There is a certain kind of higher blood glucose level than normal patient during surgery. The stress of surgery is because of, what happens whenever there is stress, whether it's due to the surgery or whether it is anesthesia, whether it is because of illness, there is increased surge of the counter-regulatory hormone in our body, like cortisol, growth hormone, and catecholamines. What they do, they increases the insulin resistance and insulin sensitivity is reduced. Simultaneously, there is decreased peripheral utilization of glucose and increased lipolysis, and there is increased gluconeogenesis. So what happens ultimately, there is hyperglycemia. When this is, uncontrolled hyperglycemia, that results in stress hyperglycemia, higher blood sugar level. And this leads to various complications during surgery or after surgery. So when the sugar is extremely uncontrolled, it can lead to osmotic diuresis and electrolyte disbalance, and this can lead to diabetic ketoacidosis, okay, and hyperglycemic or hyperosmolar hyperglycemic non-ketotic syndrome also. And we have to therefore have good control. And besides this, what happens during surgery, there is increase in post-inflammatory markers, and this leads to endothelial dysfunction, hypertension, and various complications related to heart. So that's why the prognosis is poor in patients who have a cardiac history. So therefore, proper management of diabetes glucose levels, that is according to ADA, is between 140 to 180 during the perioperative period and intraoperative period, and to avoid hypoglycemia less than 70 milligram per deciliter blood sugar, and hyperglycemia more than 180 milligram per deciliter blood sugar should be the target. Yes, you can proceed further.
All right. So how is it important, if you can tell us about that?
So it is very important because it is directly related with the prognosis of the patient post-operatively, intraoperatively, in fact. As I told you, like during surgery, suppose the patient develops hypoglycemia. Hypoglycemia can also happen. This is mostly heterogenic. Like when there is mismatch between the insulin doses and the, or timing of the doses, that can lead to hypoglycemia too. So we have to first correct the hypoglycemia and then we can proceed for the surgery. But suppose the sugars are really high, like more than 250 milligram per deciliter is the blood sugar level. So chances are there that the patient can lead to diabetic ketoacidosis. So we don't want to that kind of hazardous situation that is associated with the high mortality rate. So we can postpone the surgery for that time period. So HbA1c is very important when we, when we select the patient for surgeries. But it is like that if the HbA1c is higher, we can always 8.5 and we can always postpone surgery for a few more days. But it is not like that. It should there is a target level of HbA1c because we have to target the perioperative management. Like fasting and post-lunch sugar should be within target levels, and blood sugar reduction should be target levels rather than HbA1c because it takes 3 months to get a change in HbA1c levels.
All right. So we talked about what is it and it's important. So can you tell us how is perioperative management of diabetes is done?
See, the perioperative management of diabetes starts with the history of the patient. We have to have, know what is the type of diabetes in the patient, how it is managed, whether it's the lifestyle modification with medication or with insulin, how much is the corrected glucose level of the, sugar, and there should be normoglycemia before surgery. So we have to keep a check on the glucose levels too. And we have to find out whether the patient is having some diabetic complications like diabetic nephropathy, diabetic neuropathy, or some cardiac problem associated with. And we have to select the surgery And the type of anesthesia is also very important in management of perioperative management of diabetes. General surgery is also more chances of ghost disturbances, and other than local surgery. But there are certain fields where we have to choose general anesthesia only. Okay, but yeah, and these cardiac surgeries, basically bypass surgeries, they are more likely associated with the higher chances of hyperglycemia rather than laparoscopic surgery sort of thing, where the fluid shift is more, hemodynamic instability is more, the chances of hyperglycemia are more. So we have to select the surgery accordingly. And what is the fasting duration before surgery? That is also very important. So that's how we select the patient, and we have to investigate accordingly. See, investigation, it requires the basic investigation like CBC, your liver function test, your renal function test, and your urine examination for ketosis and all, ketonuria. And then chest X-ray, baseline ECG, these are very important things. And when we are looking for diabetes patient in particular, we have to see that the patient should not have higher blood pressure levels too. And the patient has having some kind of diabetic neuropathy signs, like patients having some kind of autonomic neuropathy, which may result in postural hypotension and other problems during surgery also. Patients are more prone for the cardiac complication. They are suffering from such kind of conditions.
All right. So are there any precautions of perioperative preparation for diabetic patients?
Yeah, as I told you that you have to evaluate the patient properly by proper history and examination with proper investigation, including the blood sugar fasting, post-surgery HbA1c and baseline investigations. We have to have select this patient for the early surgery. Early like fasting duration is lesser during that time, and then we have to decide which kind of anesthesia we are giving to the patient. And then we have to see the patient. If the patient is on oral anti-hypoglycemic agents, we have to withhold those oral anti-hypoglycemic agents on the day of surgery. Because they have longer duration of action, first of all, and then they have prolonged onset of action is delayed, is delayed, as well as there is prolonged duration of action. So what happens? It is very challenging to titrate these oral hypoglycemic agents for the shorter duration of period of management of hyperglycemia. So we withhold the oral hypoglycemic agents in the morning, and you are aware of the things like metformin, for example. If we give to a patient who is having some kind of renal dysfunction or has received IV contrast, so patient may develop lactic acidosis. If the patient has taken some kind of insulin secretory like sulfonylurea, patient may develop hypoglycemia. If the patient was on SGLT2 inhibitors and we keep continuing those medications during surgery, so patient may end up with the normoglycemic ketoacidosis also. So there are various problems associated with. That's why we withhold these drugs, during the day of surgery. Then, if the patient is on insulin, so what we do, we have to reduce the dose of basal insulin. Basal insulin, 20 to 25% of the basal insulin, like glargine insulin and all, they are reduced to 20 to 25% prior to the evening of the surgery. And suppose they are taking twice a day, then we reduce both the doses, morning and evening doses, by 20 to 25%. But suppose patient is having on higher doses of insulin, like more than 80 units per day, or requirement of basal insulin is more than 60% of the total insulin requirement, or the patient is having chances of higher chances of hypoglycemia, like patient is having hepatic insufficiency or renal insufficiency. In that condition, we have to reduce further the dose of insulin, like 50 to 75%, to avoid hypoglycemia. I suppose patient is on ultra long-acting insulin, we have to do these adjustments at least 3 days prior to the surgery. And if the patient is taking intermediate insulin, like 30/70 NPH and regular insulin, or protamine aspart insulin, so in that case, we have to either we have to shift on longer acting insulin prior to the evening of the surgery, or we can reduce the dose by 50% of the these 30/70 insulin in the morning before surgery. And we can then shift on, like, during the surgery, we have to have sliding scale, like, corrected insulin doses should be given, according to the level of the sugar during the surgery intraoperatively. And suppose patient is having some problem, so we have to directly shift on the continuous intravenous insulin infusion. Then we have to check blood sugar every 1 to 2 hourly during surgery for that. Because why these are chosen intravenous insulin infusion, because when we use this kind of thing, that time we use regular insulin. Regular insulin is shorter acting insulin. Shorter acting, so titration of doses is easier. When we use subcute insulin, that time if suppose patient is a hemodynamic instability, so and vasoconstriction is there, so that time the absorption of subcute insulin is unpredictable. So we prefer dose titration with the IV infusion of insulin during surgery. And we check every 1 to 2 hourly the blood sugar levels and adjust the doses of insulin accordingly, like that. And then once this period is over, so post-operative period, which is suppose some patients are on just for shorter duration of surgery, or they are started taking oral feeds, they can be discharged early. And suppose patient is on non-critically ill patients, they can be shifted if they are taking orally. They can be shifted on both basal insulin doses as well as prandial insulin as well as correctional insulins. Basal insulins basically covers the fasting period of the patient, during night time, okay, in between meals, okay. And these prandial insulins, suppose patient starts taking orally, so each meals before that certain amount of insulin is given, okay. So suppose a patient is on total dose insulin is X amount, so one half of that amount is given as basal insulin, and 1/6 of that total amount is given with each meals thrice a day. That's how it is corrected in non-critically ill patients. And suppose patient is having some kind of critical illness, so we continue the IV infusion of insulin, and we check the blood sugar every 1 to 2 hourly, and accordingly, like every institution particular protocol or sliding scale, accordingly we adjust the level of insulin in the infusion, how many units to be given according to the blood sugar level of the patient. Okay, then once the patient, this glycemia is under control, suppose 80 to 1 to between the 81 and 80 milligram per deciliter range, we shift to the we try to shift on intermediate acting or a long acting insulin, subcute. So with that is dependent upon the how many, if the patient is hemodynamically stable and there is no further vasoconstriction state, and patient, then we can shift slowly over these intermediate acting subcute insulins. But there should be overlap period, because intermediate insulin takes little time to act, and the shorter acting insulin which we use during intravenous infusion, they are very short acting. So we have to have an overlapping period of 2 to 3 hours minimum while doing this. Okay.
So we know, we have an idea how diabetes can be risky for it. So why is diabetes a risk factor for surgery? If you can tell us about that.
Yes, very good question. Because what happens, when you are diabetic, the chances are infections are, post-operative infections are more, wound healing is less, and post-operative stay in the hospital is also prolonged because of infection and other related problems. See, in orthopedic surgeries, local wound infection is also important. And there are certain infections like pneumonia or sources of urinary tract infections are also more in diabetic patient during the hospital stay post-operatively. Okay, suppose we are having some implant, so implant infections and the other chances, of complications associated with the diabetes can increase. Suppose patient is having some cardiac issues earlier, okay, and patient is having hyperglycemia, the chances are there that they can, the morbidity increases. Suppose patient undergoes angioplasty, so there are chances that patient may end up with some kind of problem if the diabetes is not properly controlled, or CABG, then patient can end up in problems. So that's why this is important. Suppose patient is having autonomic neuropathy, chances of cardiac arrest is also there. So, and we have to just see when we are treating the patient, that patient should be properly controlled, because the diabetic patients have certain problems like, cardiac problems, as I told you, hypertension, cardiovascular diseases, coronary artery diseases. So myocardial infarctions are also there post-operatively in patients. That too is silent, like, patient doesn't know that patient is having pain or something. Science means silent angina, we say that. Okay.
All right. So how does diabetes really affect the recovery of surgery?
As I mentioned to you, because of all these problems, as infection, delayed wound healing, so the duration of the stay of the patient increases. So suppose the patient develops infection and that turns into the sepsis and all. So that it is also with a high mortality rate. So therefore, proper management of diabetes pre-surgery, intraoperative, and post-surgery is very important.
Thank you so much, ma'am, for giving us deep knowledge inside the concept. Do you have any message for our audience?
Yes, my message is like, when you are planning for some any kind of surgery, you have to have proper blood sugar control before you go ahead for the with surgery. And during surgery also, you have to have certain precautions. I told you, during the day of surgery, you have to withhold these oral anti-hypoglycemic agents. You have to do adjustment regarding the doses of insulin before surgery. Before surgery, before the evening of surgery, in the morning of the surgery, and when the post-operatively also, you have to manage insulin levels and manage the glucose levels, and proper checking of sugar levels are very important. And you know what? All these ambulatory and societies for management of the hyperglycemia, ambulatory society for anesthesia, they suggest that it should not be very stringently control sugar. It should be less than 180, but it is not very tightly controlled. Like ADA recommends between the control of perioperative control between 80 to 180 milligram per deciliter, and avoidance of hypoglycemia like less than 70 milligram per deciliter, and hyperglycemia more than 250 or 180 milligram per deciliter. So with this, we can have a good control of sugar during the surgery and post-operatively, and we can avoid the complication associated with hyperglycemia, like acute complication, as I mentioned, diabetic ketoacidosis and diabetic ketoacidosis and hyperocular hyperglycemic ketotic, non-ketotic syndrome. These are the acute complications, as well as post-operatively patient may end up into certain bodily infections like pneumonia and urinary tract infection and sepsis too. So with this, we can avoid all this complication and implant rejection also, So it's very important to control the diabetes.
Thank you so much, ma'am. Thank you so much for being here with us today.
I hope I have fulfilled all the questions properly, explained everything.
Of course.